How to treat patients with clear aligners. I think there's a lot we can learn from treated orthodontic cases, and I'm Dr. Nagy. I teach orthodontics to GPs and specialists, and I like to go over these example cases because I think there's a lot we can learn from them. This is a published clear aligner or Invisalign case. Here's the doctor that treated this patient, and let's just review this case. Okay, so let's go to the records first, because what you want to do first is always take records. Okay, so here are the start pictures. So obviously this patient had some space, but the other thing they also have is they have a deep bite. So whenever you see the upper teeth covering up the lower teeth more than maybe 20%, that's considered deep bite. So this would be a deep bite about maybe 90%, pretty significant. If you look at the upper arch, they have some rotations, no crowding on the upper arch, but they do have some spacing. If you look at the lower arch, they do have some crowding. Remember, when you look at crowding, you want to look at the overlaps to see. If you come here, maybe you see like 1 millimeter crowding there, maybe 0.5 and 0.5 here, so that's maybe 2 millimeters. So maybe about 3 millimeters of crowding on the lower arch. Upper arch had spacing. One of the other things that we notice here too is this really strong frenum, and this patient does have a diastema, this space between the front two teeth. So I would make a list. Whenever I'm working on orthodontic cases, I always make a problem list. So on a problem list, there's a few items we need to list. One would be spacing on the upper arch and a diastema between 8 and 9. In orthodontically, we would call these ones because we start numbering from the front. They also have a strong frenum. The other thing you want to add to your problem list, it would be rotations on both on the upper and lower arch, and obviously spacing on the upper arch. On the lower arch, we would want to add probably about 2 to 3 millimeters of crowding, both posterior and anterior crowding. Let's look at the side view. So this patient would be class 1. Class 1, remember, for orthodontically, for class 1, the upper canine should be between the lower 4s and the 5s. We don't look at molar class 1 so much, because that if you have a kind of like a traditional dental school class 1 at the molars, that's going to give you too much overjet. So this patient has just dental school slide class 3, which in orthodontically, or in orthodontics, we would call that super class 1, which is about 1 millimeter class 3, and that gives you this really nice class 1 occlusion, which actually this patient actually is class 1 on both sides. Canine here class 1, molars about 1 millimeter class 3, which is orthodontically would be, a lot of the orthodontists will call this super class 1, which would be dental school 1 millimeter class 3. Now the other thing you want to notice on the side view is that this patient has a really deep curve speed. Curve speed is this curvature of the lower arch, and that creates this deep bite, which we already talked about. So that would go on your problem list. That this patient has a deep bite because the upper teeth overlap the lower teeth. And if you look at the side view, this patient has a deep curve or speed, which kind of gives you this deep bite look. And deep bite look makes you look older. You know, the youthful look is whenever you have this overlap of the upper teeth overlapping the lower teeth, that kind of makes you look older. So it's very important to correct the deep bite. It's something that you know we don't talk about very often. I teach this all the time. So if you want to make your patient looks really youthful and young, you definitely want to work on the deep bite. Okay. So what goes on our problem list? So we get class 1, which is good. So that's not a problem. We get spacing, we got rotations, we got crowding on the lower arch, spacing on the upper arch, and then we have a deep curve or speed and a deep bite. So that's our problem list. Now, whenever you come up with a problem list, you should have some kind of a solution list as well. So we're going to work on that. First, we are going to look at the Panrex. One of the notes I can note on the Panrex is I think I would check this out. I don't know what that is on the x-ray. Make sure there's nothing going on here with pathology. I would look at the condyles. Those look pretty good. And then I do see the third molars with the exception of 17. So the third molars, I think it would be a good idea to get those out. I don't see a ceph for this case, which is a problem, but we'll just move on from that. That's another topic of discussion. So again, we get our problem list, and what would be our solution list for the problem list? So one of the things for the frenum, obviously we would want to do some kind of a frenectomy, because as soon as you close these spaces, the spaces will open up if you don't deal with the frenum. So I would put on a list of frenectomy for the strong frenum, and I would of course close the spacing and correct the rotations and the crowding. On the lower arch, we don't have significant amount of crowding. Oh, that's after, sorry, here we go. We don't have a significant amount of crowding, but I think if you need any IPR, maybe just a little bit in the anterior area, but not much, maybe just like 1 millimeter at most. And it's possible that you probably won't even need any IPR in this case, but at most maybe 1 millimeter. Now the other thing that we need to make note for is a deep curve speed. So to correct the deep curve speed, we need to do some intrusion of the anterior area. So I think I would ask for some attachment that's going to create an intrusion on the lower anterior area to correct the deep bite. So I would design the clean check based on those recommendations, and here is one. Here we see the attachments, and they ended up not putting intrusion attachments, I think, on the anterior area for some reason, but I think I would add those, and you can tell that, you know, they're correcting the deep curve speed very nicely, and they have a lot of attachments even going back to the second molars. That's for mainly for anchorage, so we can intrude the lower anterior teeth. So that looks pretty good. And like I said, the main reasons for these attachments is to have a good anchorage for the trays, so we can intrude the lower anterior teeth, and you end up with this nice youthful look by correcting the deep bite, by correcting the deep curve speed. Now, if you heard me talk about this before, you have to be careful that you don't run out of overjet with these class 1 cases, because if you do run out of overjet when you treat these patients, what will happen is you can end up with a posterior open bite. Now in this case, we're not really worried about running out of overjet, because we do have a low overjet here, but you do have to be a little bit careful, and this is why I would like to see a ceph here to see how much proclination or forward dumping of the lower anterior teeth we have. But I think in this case we are going to be okay. We get some spacing on the upper arch, and then the posterior open bite topic is another big topic, so we're going to talk about that in the upcoming another case. But in this case, I think we'll be okay with the posterior open bite, because I do see some overjet here, and by the time we run out of overjet by closing these spaces, remember when you close these spaces, you are going to reduce the overjet because you're constricting the upper arch by closing these spaces. Now the other thing I would do is, once I correct this, I would definitely put a lingual retainer, just maybe 2 to 2, just to keep these spaces closed, because these spaces will want to come back. And then the other thing that you see is, you see these constrictions of the posterior arches. You can correct that very nicely. I don't see a cross bite, so there's no need for expansion, like true expansion. When you try to expand with the trays, all you're gonna get is tipping. So we don't want to do that, but we can we can round out the arches very nicely and align everything. So what do we look like at the end? So here's the finished picture. They actually did a super nice job correcting the deep bite. If you look here, going from here to here, that looks very nice. They also did a very good job correcting the deep bite from the side view. If you look here, the patient, you couldn't even see the lower teeth at all. The upper teeth were completely overlapping it, and now they still have a little bit of a deep bite, but I think it's a lot better than it was. You can really tell from the front view. This looks really nice compared to that. This is still just a little bit of a deep bite. It's nothing to worry about. I think it's maybe like 50%. I think I would go just maybe 10 more percent to see a little bit more of these lower anterior teeth, but it's pretty good. I like it. It looks really nice, and the lateral view, the side view, looks really nice too. So this is the panorex at the end. They didn't take out the wisdom teeth. They look about the same as before, but that doesn't really do much to this case. I think I would have taken the wisdom teeth out. So this is the review for this case, and I showed you the clean check, and this was their the thing that they're accomplished. The one thing I don't see is the fixed retainer. I think I for sure do a fixed retainer for this case, because otherwise I think these spaces are going to come back. Even though you did the frenectomy, the gingiva will pull on these teeth, and I think the space will come back if you don't put a fixed retainer here. And I think I would just go probably 2 to 2. 2 just means lateral to lateral, because remember in orthodontics we number from 1, 2, 3, 4, 5, 6, 7, 8. So that's how we number the teeth. So 2 to 2 would be upper lateral to upper lateral. So nice case overall. I really like it. I think they did a super good job, and hopefully you get some notes. If you have any questions, I'll leave my links below this video. Welcome to reach out, or just post your questions below this video, and hopefully you find this useful. Have a good day. Bye.